First topic is to be dealt with by Dr. Greeshma MG, faculty at Regional Institute of Ophthalmology, Trivandrum Medical College, and she will be giving us an insight into optic disc pathologies. Over to you, Dr. Greeshma.
Thank you, madam. Good afternoon to all. Today, the topic of my presentation is an insight into disc pathologies. So I thank KSOS for this opportunity. So the optic disc is a vulnerable zone because it's a zone of transition. There is a transition from a high pressure intraocular system to a low intracranial pressure. The axons are myelinated posterior to the optic nerve head, and the blood supply also, it's a watershed zone. The blood supply being changing from the central retinal arterial circulation to more of a posterior ciliary circulation. The cell types of the optic nerve is mainly the axons of the ganglion cells, supported by the astrocytes, capillary associated cells, and fibroblast. So the anatomy is important, wherein the optic nerve exits through the opening in the sclera called the scleral canal. So when the scleral canal becomes narrow, the optic nerve becomes more crowded, leading to the so-called optic disc at risk. And there are small openings in the scleral canal called the lamina cribrosa. So these are small round openings which become slit-like when the intraocular pressure is raised. So when they become slit-like, they compress the optic nerve fibers, leading to an ischemia. The angle of exit of optic nerve is also important because normally it exits perpendicularly, and when it exits obliquely, sometimes like this, you can see there is a tilting of the optic nerve head with crowding of optic nerve fibers at one end and a temporal crescent at the other end. So this gives an appearance of a pseudo disc edema. So swollen disc is one of the important clinical scenarios in our practice. We have to always distinguish between a true disc edema and a pseudo disc edema. So a thorough disc evaluation is mandatory. Look at the media for any evidence of vitritis to rule out any inflammation. The disc should be thoroughly examined for its size, color. The contralateral disc should be examined. The neuroretinal rim is very important. Rather than the cup, the neuroretinal rim color is very important. The margins of the disc, if disc edema is there, whether it's sectoral or a diffuse disc edema, identify any congenital anomalies of disc is there, and any scalloping of the disc surface which might give you a clue to a disc drusen. The vessels are to be examined thoroughly, the vascular signs, and the pedipapillary retinal examination is very important. Look for any retinal or choroidal folds, the background retina, macula, and periphery, because even an intermediate uveitis can present as a disc edema. So never to miss all this in a case of disc edema. So the most important cause of bilateral disc edema, as you know, is a papilledema and hypertensive retinopathy. But any unilateral cause can present as bilateral edema. So other causes mainly which present unilaterally are inflammatory and vascular causes, and others like toxic causes, hypotony, hereditary, infiltrative, and compressive lesions. So any of these can present unilaterally or bilaterally. Systemic diseases usually present as bilateral. And you have to always remember that in a clinical practice, an atrophic disc cannot be used to assess a disc edema. Whether we cannot assess whether the disc edema is increasing or whether it's recurring. But because as we say, the dead axons do not have the capacity to swell up and manifest as a disc edema. So this is a case. She was a 50-year-old female. She presented to us with the complaints of occasional headache and tinnitus. Her visual acuity was 6/6 in both eyes. Right eye actually showed a mild temporal disc pallor. The left eye showed frisson grade 1 to 2 disc edema. So when we evaluated, she had a sphenoidal meningioma, and it was planned for a neurosurgical intervention, and later on the patient developed third nerve palsy. So it is imperative to diagnose disc edema at the earliest. This was a 30-year-old female. She presented with a bilateral disc edema. The vision was 6/6, no neurological deficits. She was actually short-statured, and she didn't look so obese, but her weight was 55 and height was 140, and the BMI came up to 28. Okay, so we suspected idiopathic intracranial hypertension and referred back to a neurologist. Her CSF opening pressure recorded to be 27, which is higher than the 25, which is upper limit of normal. So it is very important that you measure the BMI of patients, the body mass index of the patients with disc edema. It can present as unilateral also, and this is a modified Dandy criteria for diagnosing IIH. So papilledema, as you know, it's because of the increased intracranial pressure that there is an axoplasmic stasis which lead on to a disc edema. There is a grading called a modified Frisson grading, where grade 0 is a normal disc and grade 5 is a severe disc edema. So this was a 50-year-old male patient who presented with right eye disc was normal. He had a sudden blurring of vision in the left eye, and the left eye disc was found to be edematous. Actually, on retrospective analysis, right eye looked smaller. The cup disc ratio was only 0.2. So we arrived at a diagnosis of non-arthritic ischemic optic neuropathy. So non-arthritic ischemic optic neuropathy, the pathology is basically because of the small vessel disease of the posterior ciliary arteries, and added on to that there is a nocturnal hypotension. So there is a sudden fall in the perfusion of the optic nerve head. So this causes the axoplasmic stasis and in turn a disc edema. So this disc edema will further compress the vessels, leading to a more ischemia, and hence it's a vicious cycle. So the clinical points you have to remember is NAION doesn't have a definitive treatment or a proven treatment. So we have to concentrate on the modifiable risk factors like nocturnal antihypertensives, obstructive sleep apnea. We have to conduct a sleep study for looking out that, and diagnose glaucoma, because treating these can improve the perfusion of the optic nerve head. And diabetic papillopathy is actually thought to be a variant of NAION, wherein the disc edema will be there. Associated with that, there will be more telangiectatic vessels and hemorrhages. So once the disc edema resolves, that also will resolve, and not to be confused with the new vessels. Retrospective analysis of NAION might be difficult, because on resolution of the disc edema, some neurons can become atrophic and the cup might look larger. Coming to arthritic variety, it is because mainly of GCA and other causes are there. The clinical points you have to remember is that the other eye disc will be either a normal sized or a large sized, and the pallid disc edema will be there and associated systemic features. So this was an interesting case. He was a 30-year-old male patient who presented with right eye was normal, left eye had blurring of vision for past 2 weeks, and we saw a sectoral disc edema was there in the inferotemporal quadrant. It was looking more like a disc granuloma. And when we investigated, and he also had a serous detachment at the macula. And when we investigated, he turned out to be IgM positive for toxoplasma. And after 10 days, his disc was completely normal, and there were more hard exudates in the macula. So we revised a diagnosis of neuroretinitis. And in our country, we have to look for more endemic causes like toxoplasma, toxocariasis, tuberculosis, sarcoid, syphilis, rather than the rarer causes. So rarer causes come only late. And these are the causes of optic neuritis, and always distinguish a pseudodisc edema. Remember, these are the causes. You can do an autofluorescence to rule out a disc drusen and ultrasound, and keep this as a alternative diagnosis only after full workup. Thank you.